resistance. It sounds so controversial. I don't mean to declare war on carbs, but the more metabolically unhealthy you are, the more that is the macronutrient that is problematic. Moderation doesn't work if you're an addict. And if you have insulin resistance, you're gonna very, very likely be a person who within a few years starts to really notice the cognitive decline.
Gosh, it's frightening.
The good news of all of this, when we recognize that what we're eating and how frequently we're eating it is a primary driver of so many problems, all right, you can change that. Protein is a friend. A human can eat fat and there will be no effect on insulin whatsoever. None. Within weeks, a person can totally reverse type 2 diabetes.
Dr. Benjamin Bikman, it is so wonderful to have you here today.
Oh, Kristen, my pleasure. Thank you.
You have done groundbreaking work in the area of insulin metabolism and have really, I think, led the way in bringing quite a crisis to the consciousness of Americans. So I just first want to say thank you for all the good work that you do. For our listeners who are new to your work, you know, what really drives you?
Yeah, I am motivated in part as a scientist and a professor to, as a scientist, appreciate the answers that we find. After all, that's what a scientist is, a person who's just trying to answer questions. I asked a question a number of years ago, at least to myself, what is the relevance of metabolic health in chronic disease? So is there a metabolic foundation to much of chronic disease? And the answer just continued to be a resounding yes.
So you had kind of a breakthrough moment that I think anyone who's worn a CGM might realize that, food does really interesting things to my blood sugar.
Right.
So we've got, I think your first one had to do with cereal. So I don't know if it was Fruit Loops. I know. Don't you just want to...
As a cereal holic, it's like you've put the drug in front of the addict.
I would literally have like a box of Frosted Flakes when I was in high school.
This is why, this is why, if you'll allow me to say, this is why I rail against this mantra that you hear so often in the realm of dietetics and nutrition of moderation in all things. Most people, it's designed to go around moderation. It's designed to hijack us, and so many people, as inconvenient as it may be to say, are addicted to refined starches and sugars. Yeah. And moderation doesn't work if you're an addict. And so, you noting the CGM and then waving a bowl of my drug of choice in front of me, it certainly makes me think about my own habits and particularly what the CGM revealed, where I would find after imbibing in my drug of choice, I would have glucose levels that would not only be elevated for 24 straight hours. It would take, even me, a lean, healthy, physically active guy, I would indulge, because I'm an addict, overindulge, to be more precise, in cold cereal in the evening. And my glucose, in the absence of any other food, for the next about 20 hours would be above 100 into the 100 teens. For me, a lean, healthy, non-diabetic guy. And then at the same time, with wearable devices, finding that my chronically poor sleep might less be a matter of anxiety and just I'm wired to sleep badly, and more actually a consequence of wrecking my metabolic state right before I'm going to bed, and most people don't appreciate. We need to appreciate that glucose and insulin are separate. Sure, we look at them as they're married. They're a couple in this relationship, if you will, but they are distinct. And by treating them as distinct, we are enabled to have a more precise view of the individual. In other words, to say all that another way, we have a glucose-centric paradigm of modern metabolic medicine. As much as we have all of these other markers that we look at with the blood test, when it comes to metabolism, the conventional clinician will look no further than glucose or A1C, some surrogate of glucose. And I'm not saying glucose doesn't matter, but the problem with insulin resistance is that it's affected more by insulin directly than the glucose, as much as glucose has an effect on insulin. It's the insulin that's driving the insulin resistance. And when we look at these two variables, if you're monitoring the health of an individual over years, insulin resistance is a state where glucose is staying normal, albeit with some variations that a CGM and monitoring can reveal is where something might be going off. But in a static, you come in for a fasted blood test, glucose may be hovering at normal, but insulin is getting progressively higher. And so my contention is we need to treat the two separately, and indeed we need to put them in their proper place, which is that insulin ought to be the primary metabolic marker, and then glucose ought to be looked at as a sidekick, or rather a symptom of insulin going wrong, but one of many symptoms. I know within your own interests in WHOOP, one of the big outcomes you guys look at is cardiovascular outcomes, including blood pressure. Blood pressure is a much more sensitive indicator of insulin resistance than glucose levels are, because glucose can stay normal. Although insulin's waging a silent war to keep it there, it's working well enough. But then as insulin's climbing, it's affecting other things like salt and water handling in a way that that is going to be an earlier indicator than the glucose problem.
So you can have normal glucose levels, but be insulin resistant.
Absolutely, yes.
Resistant.
Yeah, resounding yes. And that's why we have to shift from the glucose-centric paradigm. Not that glucose doesn't matter, but maybe rather than shift, we need to expand it to say, well, we have to include the insulin component to this.
So is it fair to say for someone who, for example, maybe hasn't gone to get a blood test, they don't know what their insulin levels are, but they're monitoring their glucose levels, and those appear normal, but perhaps their blood pressure is a little high. So maybe they go and they do a cuff, or they have a device that is able to measure their blood pressure, and maybe their HRV is on the low side, and resting heart rate maybe is on the high side. You know, is that kind of a window into what might be happening metabolically?
Oh, absolutely right. Yeah. So insulin, one of the reasons I wanted to, put these thoughts into the book or this kind of all-encompassing view of, as much as we have all these chronic diseases, they share a common core. And I'm kind of acting out almost a tree where we have all these branches, and one of the branches is going to be cardiovascular health. Well, that's coming off the same trunk of insulin resistance that things like infertility and cognitive decline are coming from. But with cardiovascular health specifically, we know that insulin, as it is elevated, will activate the sympathetic nervous system. And if you have a chronically elevated sympathetic tone, well, good luck having a normal HRV. You are going to constantly be up in that narrower range. You are narrowing down the ability of the heart to be slowing and accelerating in a normal kind of dynamic pattern, which would give you a good HRV.
So autonomic nervous system dysfunction is a marker.
You could say you have an autonomic dysfunction. At the same time, you could say you are not allowing the sympathetic to turn into the autonomic or to give way to the autonomic.
Right.
Because insulin and glucose, when they're elevated, back to my bad sleep habits, it forces the system into a nervous state and dampening the autonomic state. And that you want autonomic to dominate if you want not only vasodilation and a reduced systemic blood pressure, but even for the HRV to be as dynamic as we want it to be, which is a strong indication of just good health and even, to your point, metabolic health.
And insulin resistance is going to impair that vasodilation.
It does. That's right. Yeah. So not only does that explain the incredibly intimate connection between hypertension and insulin resistance, but even in men, it is considered to be one of the earliest instances of how insulin resistance is driving erectile dysfunction. So the most common form of infertility in men is directly attributable to some degree to this metabolic problem that is insulin resistance.
Jeez. It's like it's the root. It's the foundation.
Amen.
Of pretty much everything.
So it brings meaning to my career. Why would I devote a career?
You're so important.
Yeah, but that's also why when I started putting these thoughts together, in the form of my book, Why We Get Sick, which you've been nice enough to put here.
I know, it's so good.
I actually had to go through several versions of the title.
So good.
The first version of the book was Insulin Resistance, Why It Matters or something.
Yeah.
But I knew no one would care. Most people hear the word insulin and think of it no further than the context of, well, it's a drug for diabetes. They just think of it as a Some people don't even know we make insulin. That's a normal hormone. Yeah, so insulin is a peptide hormone, a little petite peptide that is produced from the beta cells of the pancreas. Now, the main stimulus of telling the beta cells to release insulin is blood glucose, blood sugar. So now that then is a separate thing, not a hormone. It's a nutrient or an energy source or calorie source.
So we ingest the Apple Jacks.
Yep.
And then what happens?
Yep. Great. So we eat a starch or a sugar, and then to some degree, that's going to be digested. But every carbohydrate to some degree is going to get broken down into blood sugar, a lot or little, rapidly or very slowly. But as blood glucose levels start to climb, that will stimulate the beta cell to release insulin. And in this context, insulin is acting as a hero. If glucose levels are too high for too long, it is acutely lethal. We need to correct it. And there's no other nutrient that does this, by the way. If you and I were to eat a load of fat would have a very slow, like we ate a stick of butter, we would notice this very slow creeping increase in our triglycerides, and it would come back down. If we ate a load of protein, we'd see amino acids go up and then come back down. Glucose, nothing changes like glucose does.
Carbohydrates are non-essential.
They are not essential. That is controversial, and most people will hear us say this, and they will think, well, but the body needs glucose. Blood glucose is not the same as dietary carbohydrate. The liver has the ability to create all the glucose the body needs. So back to the glucose exchange or excursion, glucose goes up too high, really high. Insulin acts as the hero saying, hey, you're too high. I'm going to bring you back down. And so among its many effects from top to bottom, it will go to the biggest tissues of the body by mass, fat mass and muscle mass. And so insulin will come to the doors of the muscle, knock on the doors, open the doors when insulin's working well, and then allow the glucose, acting like a gatekeeper, to come from the blood into the muscle, thereby lowering blood glucose, ideally, quite quickly. And then we've returned to homeostasis.
And a person who can do that would be considered to have good insulin sensitivity.
That's right. Glucose levels can come up and down. Ideally, with monitoring devices, we'd want to see glucose levels get back down to around 100 milligrams per deciliter by about 2 hours. That's a good sign. So there is value in the dynamic testing of glucose that we don't get with just a
which
once
you can do with a continuous glucose monitor.
Right.
And that's
rather than
really
like
valuable.
one time a year we fast to get our blood drawn.
Right. And there's so many confounders that can influence that one moment in time.
That's right.
Yeah.
But insulin doesn't come down as quickly. It sort of lingers in order to determine, all right, is everything back to normal here? Okay, it is now, I'll go away. And so insulin, even in an insulin-sensitive person, can stay elevated for up to 3 hours, just with even a modest amount of carbohydrate consumed. And unfortunately, in our modern environment, not only do we have that 3-hour window of insulin, but if you're an insulin-resistant person, you could eat that same carbohydrate load, and now insulin might be elevated for 5 or 6 hours. Well, long before insulin has even had a chance to come back down, we've spiked it again because we have this culture of chronic carbohydrate consumption. So we start the morning off with a bowl of starchy, sugary foods, and then we have a mid-morning snack or sugary drink, and then we do the same thing for lunch and throughout the day. So we're spending every waking moment
so our insulin
in a state of elevated insulin.
So hard.
Yep. And like happens so often, too much of a signal results in a deafening to that signal.
So insulin no longer becomes responsive, insulin resistance.
That's right. Yep. So too much insulin is the main driver of insulin resistance, and our carb-crazed culture is what's driven it.
So what happens? So that for that person who's having the Apple Jacks, at 9 p.m., a couple hours before they go to bed or whatever, they do it once, not a big deal. 2 times, not a big deal. But I think what you're saying is that the more you do that, the more stress you're putting your body under. And how long does it take for that kind of chronic carbohydrate consumption throughout the day to put you in a situation where you're maybe pre-diabetic, and then diabetic?
Right. Well, it's actually faster than most people would think, and I can cite specific studies to support it. There was a paper published on young, healthy, college-aged individuals. So these are the most metabolically bulletproof people you can find, right? Think about the average college student. They're doing all kinds of horrible things to their bodies, and yet they're still reasonably fine.
Yeah.
So that just helps us put this in perspective. So even the most metabolically immune among us still had this happen. So over a 6-day period, they had these individuals just simply overeat carbohydrates more than they needed, which, as we noted, is essentially zero. But they took the average, what they were eating, and then just said, all right, stack on some extra carbs. In just 6 days, their insulin levels in a fasted state had, if I recall correctly, gone up by about 3 times. So their fasted insulin had gone up by about 3 times, but their fasting glucose was still normal. Again, back to this original point that if we had a metabolic view, which was just glucose built, we would miss this. So in as little as a week of a little bit of carb-induced self-abuse, you can have demonstrable insulin resistance settle in. Yeah, I actually always start these conversations with insulin. And that enables a conversation because most people are just familiar enough to kind of think they know what it means, but unfamiliar enough that they're going to want to be a little curious. And so I try to take this kind of holistic view where I say, hey, you are taking a blood pressure medication, you are taking a migraine medication, you are taking maybe a fertility medication. Imagine if rather than, and that almost enables this view where we look at them all as utterly siloed, unrelated problems because there's a medication for this one, a medication for that one, and for that one. But the reality is all of these are, back to my earlier metaphor, branches coming off the same tree. And the medication is simply clipping at the branches only for them to grow back because it's an ineffective approach. So to put that another way, all of these medications that we take are only treating symptoms that in this instance of the three I mentioned, what was it, blood pressure, migraines, and I don't know, maybe it was, I don't remember the other one I mentioned, infertility. They are all to varying degrees manifestations of the same problem. And so to me, that is sobering, but it's also encouraging because as much as a person who's, say, taking these three drugs for these three problems, they're looking at this as almost hopeless. I'm on this drug for the rest of my life. And indeed, if you are taking a drug to try to solve this, what is a metabolic problem, you will be on it for life. It will never actually solve the problem. And moreover, perhaps the most encouraging of all is that that doesn't require medications, that just requires lifestyle changes, which is, of course, easier said than done.
Tie that back to sexual health. Oh,
yeah. The metabolic connection to fertility and sexual health is robust. Like every problem is people listening may think, they're rolling their eyes by now thinking, how many things can Ben connect insulin resistance to? Oh, a lot. And this is another...
there's more, but yeah.
So let's start with men, just because male fertility is so much simpler, but it's still critical. So I would say two things. One, we've already mentioned the connection between insulin resistance and erectile dysfunction because of the challenges of a dynamic blood flow change. Right. And if you have a blood vessel that stays insulin resistant, it stays constricted. And if you can't vasodilate, you don't have normal erectile function, so erectile dysfunction follows. And then second, testosterone is a hormone that matters tremendously. Right. And we hear a lot of buzz lately, appropriately, about how nowadays a 20-year-old's testosterone levels were 20 years ago what it was in a 65-year-old man. Like testosterone levels in men are just plummeting in real time. We often have a paradigm that says, man, you've gained weight because you're low T. And testosterone is a fat-burning hormone. It doesn't want the body to burn fat. It is, in fact, the other way, that if you look at the person who's overweight, the man who's overweight and low testosterone, that's probably a consequence of actually having fat cells that are too big. So one of the quirks of male physiology is that as fat expands, it increases the expression of an enzyme called aromatase. And aromatase is an enzyme that will take testosterone and convert it into estrogen. Most people don't appreciate that all estrogen in men and women was once testosterone. Then the ovaries and the testes will just convert a certain amount of that via this enzyme aromatase. Now, ovaries convert a lot more. So in the female, her testosterone levels are here and her estrogen levels might be about here. Still, testosterone's higher, importantly, gals. In men, it'll be like this because aromatase isn't quite as active. But in the man, his fat cells start to act like her ovaries, where it is now taking the testosterone that the testes are producing, literally pulling it in, having the aromatase rearrange it, clip it apart, and send it back out as estrogen. So he has this 1-2 effect, this two-part punch, which is, one, depriving him of his testosterone and all the metabolic magic that comes with it, but at the same time increasing his estradiol, which may be telling his body to store fat in ways that are awkward for the male physique to store, and just not feeling like the testosterone wants him to feel, like this big, strong, capable man. Now, so low T compromising erectile function and fertility, that there's a huge metabolic component to both erectile dysfunction and then the testosterone reduction itself. In women, polycystic ovary syndrome is the most common form of infertility in women, increasingly common worldwide. There is an effort, actually, among fertility specialists to change the name and call it some form of metabolic infertility, which is a much more accurate term. So this comes back to insulin's, one of its many effects is to affect the actions of that enzyme aromatase. And so in a person who is insulin resistant, in this woman, her insulin levels are high, which always accompanies insulin resistance. That enzyme aromatase, which is attempting to convert testosterone into estrogen, gets inhibited by insulin. So when insulin comes to the ovaries, one of its many effects will be to tell aromatase to work less. Now, her ovaries are releasing too much testosterone, which will cause the woman with PCOS to have some of the symptoms like acne or male pattern baldness, which are both testosterone effects. But at the same time, she's not getting sufficient estrogen to promote, to work with the LH surge, both of which are necessary for ovulation itself.
Luteinizing hormone.
Yeah. So you have luteinizing hormone LH from the anterior pituitary, which is interacting in a really dynamic way with the ovaries to really overactivate aromatase to release a lot of estradiol, or the main estrogen. Both of those are essential for ovulation.
The compensatory mechanisms in the body are just wild.
Oh, yeah. Yeah, well, especially with endocrinology, which is why I love it so much as a science, and especially in the female fertility cycle. It is just this beautiful mass of organization, which looks like chaos, but it's, of course, intricately well organized. But suffice it to say, when insulin's too high, it disrupts that surge, and as the surge is disrupted, ovulation does not happen. Now, all of these follicles, which had been growing throughout the normal follicular phase, the follicles developed during the follicular phase, one becomes dominant because of the estradiol, the estrogen, and the LH surge, and then that is the one that will ovulate. And then once that ovulates and you enter into the luteal phase, which is defined by the corpus luteum, the remnant structure which released the egg, the ovary has this remnant structure on it. It dictates the signal change to all the other follicles which had been thinking they might be the winner to go away. And so as the ovary was literally expanding in volume, now it shrinks back to normal as all these follicles would have been developing. But if she doesn't ovulate, all of those follicles stick around, and now they become cysts. And now her ovaries are getting bigger. And she starts going through another cycle, and they get even bigger, and that can be exceptionally painful. And that explains the physical pain that a woman may experience with PCOS and her disrupted cycles. But once again, as discouraging as this all is, the good news is that this is something you can grab and change when you acknowledge the metabolic underpinning of this somewhat ambiguously seeming form of infertility. The brain is very sensitive to metabolic changes because it has such a high metabolic rate. It is such an energy hog. We demand so much of it, no surprise that it demands fuel in turn. And insulin is the master metabolic hormone, so it's no surprise that insulin has an effect on this master metabolic organ. Part of the brain, and indeed the neurons involved in cognition, require insulin to open the glucose doors. So that provides an immediate relevance to insulin and an explanation for how insulin resistance compromises the brain. If these sections of the brain are not responding to insulin, they're not able to get sufficient glucose, now they go hungry, and like an engine that's running out of fuel, it starts to chug along and perform more poorly. But all the more reason to let it be the hybrid and give it ketones. But even then, the ketones become a problem in their absence, because if a person is insulin resistant, insulin levels are elevated. That is a core feature of insulin resistance. Insulin levels are high, so not only is it not working well at the brain to allow the glucose in, that high insulin is at the same time compromising the liver's ability to make ketones, which would circumvent that roadblock in glucose metabolism. But I think it's sort of a metabolic version of the rhyme of the ancient mariner. This is an old piece of poetry, and this is this sailor who's stranded at sea and bemoaning the irony of him dying of dehydration while being surrounded by water. And so he bemoans his fate. Water, water everywhere, he says, nor any drop to drink. There's a metabolic analog with the brain and metabolism where the person may ironically be hyperglycemic, but because they're insulin resistant, that glucose isn't getting into the brain. So the brain is bemoaning its metabolic fate and saying, glucose, glucose everywhere, but none for me.
Hyperglycemic, elevated blood sugar.
Yeah, glucose is elevated. I can see it there in the blood. Just give me enough to meet my energetic needs. Not only is it not getting enough, despite the body swimming in a sea of it, but the fuel that it's calling out for, give it a life preserver, give it a bottle of fresh water in the case of the dying sailor, the ketones, namely, are unavailable because the high insulin is driven by the high glucose, is preventing the ketones from being made. So the brain is starving in the midst of plenty.
Gosh. So the starving brain, or the brain that is less good at using glucose as fuel.
Let's call it the starving brain.
The starving brain.
It's not inaccurate because it can't get enough fuel from glucose. Dr. Stephen Cunnane, the gentleman scientist I invoked earlier, he has shown in humans, even in women with insulin resistance as early as in their 20s, he has found that if they have insulin resistance, he detects a demonstrable reduction in their brains to take in and metabolize glucose. So this is something you can start to see as early as people in their 20s.
And this is going to manifest as brain fog, fractured memory or inability to
even
remember
irritability,
things, like
I would say. Even irritability, yeah. So the person just may feel a bit anxious.
Yeah.
They would certainly start to have some degree of, oh gosh, I just can't remember. What was that phone number again? Or what was that address again?
Yeah.
So at that earliest stage, it's difficult to kind of really put a pin in what the symptoms would be. But what is so sobering is realizing that is as early as you can start to detect some of these problems. What would be interesting is then to follow up with them 30 years later. When a woman loses the protective effects of estradiol, which is tremendously and directly beneficial to the brain, it's no surprise that now these metabolic problems start to come to the fore because there's not enough estradiol to kind of make up for it. Because estradiol is a powerful neuroprotective signal. As it goes down to these kind of male-like levels, she's lost that protection. And if she comes into that with already compromised brain metabolism,
it is just a triple whammy.
Good luck. Yeah. You're going to very, very likely be a person who within a few years starts to really notice the cognitive decline. The good news of all of this, the gospel message here of these chronic diseases is that the empowerment, and when we say, yeah, but they all have a metabolic problem. And that same metabolic, like the same young woman now who's worried about Alzheimer's disease may, in fact, be dealing with PCOS, the most common form of infertility in females. Well, what wonderful news that the same interventions you would make right now to help enhance your fertility and normal menstrual cycles and getting rid of your PCOS are the very same steps to help make your brain as resilient as possible to avoid that cognitive decline that we see in grandma at the moment and help your brain and your cognition maintain its function until the point of death. And so my lab published a report finding that we took 11 women with full-blown type 2 diabetes, and in just 90 days, with just these simple but not always easy interventions, these 4 pillars,
protein,
fat, and frequently fasting. Yes,
intermittent fasting.
We took those 4 pillars, and in just 90 days, every single one of them had reversed their type 2 diabetes. No drug injected, no pill popped. It was simply by changing what was going in their mouth and how frequently it was going in. So yeah, within weeks to just a few months, a person can totally reverse all of this. In fact, it's so fast that if a person listening to this is a type 2 diabetic on multiple drugs, like you're taking a drug for your glucose, you're taking a drug for your blood pressure, you actually need medical supervision because you may need to start getting off those drugs within as little as a few days. It's that quick.
So all of these chronic diseases that we're all familiar with, cardiovascular, metabolic, if you can stabilize, if you can become more insulin sensitive, you will improve your situation to the point of reversing whatever that disease is.
Yes. Now, I don't want to, it's hard for me to make a perfect exclamation mark claim to that, but to some degree, so I'll soften it a little bit, to some degree, you are either going to fully reverse the problem or substantially improve it. Like, for example, type 2 diabetes, it'll be gone. Based on multiple reports, my own included. You can remove that disease without even a hint of it. Alzheimer's disease, if we're talking about our kind of 80-year-old grandma with significant Alzheimer's, no.
Right.
You've done some irreparable damage to those neurons, and they're not going to come back. However, the evidence is also clear that you can still improve it. So maybe, Grandma, you're not going to perfectly correct the memory and some of the deficits, but now maybe she can get up and dress herself, which was something that was reported on in some of these case studies that I referred to earlier. So to some degree, you can reverse it, if not all the way, even any reversing is better than just slowing the decline.
So there's a laundry list of symptoms that would make me believe, okay, so I might be insulin resistance here, and I need to go to the doctor. What would be that kind of those warning signs or that laundry list?
Yeah. We've already mentioned high blood pressure. That is a really consistent, reliable marker. So if someone has high blood pressure, it's likely that you have insulin resistance that's driving it. There are other causes, but that's the most common one. Actually, we don't even need to look too far. The skin can be a window to the metabolic soul, if you will, where as a result of insulin resistance, a person can start to manifest with two distinct skin disorders, coincidentally both around the neck. And this can happen anywhere skin is just folded and kind of rubbing. So it can happen on the armpits or the groin area as well. But two distinct disorders. One is called acanthosis nigricans, which is a term to describe a darkening of the skin. Now, depending on someone's natural pigment, it can be harder to detect this or not. If you're a pasty, freckled guy like me, it would be pretty obvious. We're right around that kind of collar line of my neck. I would see this darkened pigment, kind of a coppery on my skin tone, a coppery section of skin. But that's not the only one, because you also, with that disorder though, mind you, even still within that same problem, you can also have a kind of, it's often referred to as a tissue paper texture, where it's like you've taken a nice sheet of tissue paper, crumpled it up, and then opened it back up. And so the skin is really just crinkled, I guess, for lack of a better. Yeah, okay. Like a crepe kind of ish paper. So right along that same area. And that's helpful because if a person has a darker pigmented skin, you might not see the pigment change, but you will see the texture change, that crinkled skin. That's one problem. The second, and people will know this probably as I describe it, skin tags. These are not like a mole or a mound of skin. They're like small little mushrooms, like microscopic little mushrooms that you will also see along the neck or the armpits. And those are also these little teeny columns of skin, a secondary sign. So if someone has acanthosis nigricans, the crinkled, darkened skin around the neck, and or skin tags, those are almost proof positive of insulin resistance. Now,
so you should be sprinting to
your
doctor.
Absolutely. If you notice this, and I bet someone listening, if they don't see it on themselves, I bet they have a loved one when they are hearing me describe this and they think, oh yeah, my mom has this, or my older brother has this.
How early should we be testing for insulin resistance?
Yeah, I would say.
And how do we do it?
Yeah.
What are the best tests?
When the person has come out of puberty, now you can start to rely more on some of these best tests. You can't rely on blood glucose. We need to measure insulin. So if insulin levels are around 7 or so microunits per mil in U.S. units, and in the U.K., in other metric countries, it'll be kind of around 40 picomole.
Yep.
That's a good sign. That means insulin is low in a fasted state, which is evidence of insulin sensitivity. As it gets beyond into the teens, kind of mid-teens, I'll say around 16, 17, that's a kind of warning stage. Where it might be a problem, but it might be fine. The reason I have to use squishy language here, which is painful for a scientist to do, is that insulin has a rhythm to it. And it's possible that you're catching it at a bit of a high point, whereas if we would have measured it 2 hours later or 2 hours prior, maybe it would have been a 5 microunits per mil. And so there is that wiggle room, which we need to account for maybe some other markers. But then anything getting into high teens and 20s, that's too high. But then in the midst of all of this, we can look at another marker, which is a really good surrogate, and that is the triglyceride to HDL ratio. So someone listening, take your triglycerides as they would come in milligrams per deciliter, and then divide it by the HDL cholesterol number. And if that number is below 1.5, and the lower the better generally, that's a good sign that you have good insulin sensitivity. So it's a surrogate but very good marker for insulin sensitivity.
And blood pressure, is that like how we triangulate?
Blood pressure is another one.
Are clinicians triangulating like this?
Oh, no. No, not at all. But I do think, you and I know what you and I have in common is a hope that the message is definitely spreading. I mean, the fact that I'm even here, a metabolic scientist, talking with you and your platform, this is evidence of things moving in the right direction. Question would be, well, how can we be monitoring it and measuring it better? My great hope is that we start to get not only some of these what's called a post hoc, like someone's getting their triglycerides and someone's getting their HDL, but we're never looking at them together. And there is a powerful synergy to taking these two parts and getting something greater, which is the triglyceride to HDL ratio. So at a minimum, having a separate metric that's taking those for the individual already and having a clinician who's trained enough to point a finger at it, but then including fasting insulin. And even I would even want to see fasting free fatty acids, the marker that we mentioned earlier. That's a sign of coming from the fat cell. One of the coolest metabolic markers is one called the adipo insulin resistance index, which takes fasted insulin and multiplies it by fasting free fatty acids. And it allows us to look at the insulin resistance right at the level of the fat cell, and which is the first tissue that really falls. That is the earliest tissue of all the dominoes that are going to start tipping in. Well, you have to beg your physician and say, hey, can you please not only check the insulin box, but can you please check the free fatty acid box? And in the United States, love or hate our healthcare system, it does allow a person to have a little more power over what gets measured than other more centralized healthcare systems.
You just have to know what to ask.
You just have to know what to ask and have a clinician who's hopefully open-minded and maybe humble enough to think that the patient may know something they don't know. Which is a big ask. The more degrees you put after someone's name, the more the ego becomes settled in stone.
How can we increase our insulin sensitivity or reduce our insulin resistance?
It's those meaning the same thing. We just lower insulin. The most powerful lever we can grasp and pull down is lowering insulin. And the best way to do that is by managing macronutrients optimally. In my view, there are 4 critical pillars that improve insulin resistance. The 3 based on macronutrients, 1 on when to not eat the macronutrients, control carbs, prioritize protein, don't fear fat, and frequently fast. So controlling carbohydrates, I put that first because it's the one that simply matters most. So the more a person can be consuming carbs that are from whole fruits and vegetables and less from carbs that are coming from bags and boxes with barcodes, the better. Now, in the midst of that restriction comes the abundance, which is fill the rest of your plate and stomach space by prioritizing protein, so high quality, ideally animal source protein, and then don't fear the fat that comes with that protein. In nature, all protein comes with fat. And not only
love sausage.
And I would say enjoy it liberally. When humans eat, as much as you and I both have a very favorable view of dietary protein, if we just eat protein alone, we do not digest it as well, and it's not as anabolic. Human studies have shown if protein is consumed with fat, we digest the protein better, and we have a greater anabolic response for muscle protein synthesis.
So if you're eating like really lean turkey or really lean beef, like bison, you're probably not getting the fat in conjunction with it, so you're not going to be able to utilize that protein as well.
Yeah, I would say be liberal with the fat. Even sometimes adding a little to it. In nature, protein comes with fat. That's how we should eat it. And then in the midst of those macros is that 4th pillar, which is just engage in some form of structured fasting. Whether it is a very deliberate time-restricted eating with what we could call mini fasts in a structured 24-hour window, or some
12 on, 12 off.
Yeah, absolutely. There are so many ways to do the time-restricted eating and the intermittent fasting. My only reminder and encouragement would be the more a person looks at longer window fasts, keep in mind this idea that how you end your fast matters much more than how long you fast. And with that in mind, just when you think about, well, how do I end my fast, go back to the pillars of managing your macros.
Protein, fat,
control carbs.
And reduce carbs. Amazing.
Right. Exercise is a great buffer because the muscles, as we've noted, are not only the majority of the human body by mass, but the ability of them to increase their metabolic rate and consume more glucose especially is unlike any other tissue in the body.
So resistance training is just like one of the best ways to
I'm an enormous advocate of resistance training. So I'm a huge advocate of muscle mass. And unfortunately, so maybe I'll start this little rant another way. If someone were to ask me, what is the best exercise to do? My answer is just going to be the one you'll do. So if there's a kind of a little old grandma listening to this and think she just likes to go out walking with her girlfriends, you keep doing it. And the more you can incorporate any modest changes, great. But minute for minute, the best thing is going to be resistance training. Build muscle any way you can. And there are lots of ways to do that, as modest as little air squats and push-ups to doing something as high intense as CrossFit. Any way you can increase your muscle mass. Not only the exercise itself is, of course, promoting an enormous amount of glucose uptake, independent of insulin, just as an aside, when the muscle is exercising, it becomes so hungry that it uncouples itself from insulin. It essentially doesn't need insulin to open those glucose stores. It opens them on its own. So you have an insulin-independent method for the muscle, the working muscle, to just be pulling in glucose as much as it wants. So during the exercise that's building the muscle, you're pulling in a tremendous amount of glucose, which is going to help your blood glucose settle down after you're done exercising. But then the act of increasing your muscle mass means you have more mouths to feed at any given moment of the day and night. So more muscle mass will mean at every moment better glucose control. Better glucose control will suggest improved fasted normal insulin, baseline insulin and dynamics, which is then going to lead to more stable and low insulin, thereby improving insulin sensitivity. So minute for minute, resistance training is the way to go. And I would encourage anyone to incorporate any amount of resistance training, whether it's body weight based or kettlebells or high velocity swinging barbells around, whatever it looks like for you, just do something repetitively until it gets uncomfortable and you can't do more, and then you've done it.
Yeah.